another edition of the DY Patil Postgraduate Lecture Series. We have a very interesting topic um, these days. Interventional psychiatry is definitely getting more and more center stage as opposed to earlier. And we have with us Dr. Reddy, who's an authority in neuromodulation, and he will be talking to us about the role of rTMS in depression as well as in OCD. So we are very grateful for him to have taken the time out of his busy schedule and graced us with his presence and his wisdom. We are very happy to welcome on our platform Dr. Kathy Metalia. She is also kindly consented to be a part of this and uh, joined us today. I'll request the host to display the introductory slides, please. Host, can we have the introductory slides, please? Hello, tech support. Can you please display the introductory slides? I think they are missing in action. Nonetheless, so like I
सर
said,
वेट अ मिनट, वो अभी सन फार्मा पर्सन शेयर कर रहे हैं सर.
हाँ, okay. So it gives me great privilege to introduce Dr. Kathy. He will then take over the proceedings and introduce Dr. Reddy. But Dr. Kathy is an MD psychiatrist from Ahmedabad. She is the owner of Sakhi Women's Mental Health and Child Guidance Clinic at Ahmedabad. She is a co-chairperson of the School Mental Health Subcommittee in the Indian Psychiatric Society in the present year. She's also an advisor to the Public Relations Subcommittee of the Indian Psychiatric Society West Zone in the present year. She's been an ex-chairperson and ex-advisor on the Women's Psychological Health Subcommittees in the West Zone. She is also the ex-co-chairperson of the School Mental Health Subcommittee in the IPS. She's got the Young Psychiatrist Award from the BPSS Award from IPS, the Dr. R.C. Maniar Best Paper Award twice, and also the A.V. Shah Best Paper Award as well. She's made various presentations in zonal, national, international conferences. She's written chapters in books. She's taken several lectures amongst medical professionals and various platforms for teachers, students, judicials. She's done a lot of community work. So clearly she is a multifaceted person. And to add to that multiple feathers to her cap, she's also an Upantya Vishrad in Hindustan classical music. So clearly a multifaceted person with an area of interest in child and women's mental health. So thank you very much, Dr. Kathy Metalia, for making the time and being with us today and gracing us with your presence. And I now invite you to introduce Dr. Reddy and take over the proceedings. I'll be back towards the end of the program. Over to you,
Th-
Kathy.
Yeah, thank you. I hope I'm audible.
Yes, you are.
Yeah, thank you so much, Dr. Rashmin, firstly, for inviting me and giving me an opportunity to be a part of your esteemed event. And thank you for your kind introduction as well. So, today's topic, rTMS. repetitive transcranial magnetic stimulation stands out as a highly sought-after treatment modality within the realm of psychiatry. Its proven efficacy in addressing treatment-resistant depression is widely acknowledged, with the added stamp of approval from the FDA. While I may not have first-hand experience with rTMS, but engaging in various discussions with esteemed colleagues who have utilized these methods instills in me a strong belief in its growing popularity. The recent FDA approval for treating resistant OCD further solidifies its standing. Beyond its primary applications, rTMS also shows promise in addressing a range of off-label conditions such as substance abuse disorder, migraine, Parkinson's disorder. And to talk about rTMS today, we have none other than the stalwart Dr. M.S. Reddy sir. From my residency to my early career, we have always seen Reddy sir as a legion sort of, and I really am excited and I feel uh, fortunate to have the honor of introducing Reddy sir. Dr. M.S. Reddy sir, Director of ASHA Bipolar Clinic and ASHA Neuromodulation Clinic in Hyderabad. He has been the past president of Indian Association of Private Psychiatry, Indian Association of Biological Psychiatry. He is the honorary secretary of Society of Bipolar Disorders, India. He has been the editor of Indian Journal of Psychological Medicine from 2006 to 2017. He is the council member of Asian Network of Bipolar Disorders. He is the member of the editorial board of World Journal of Biological Psychiatry. He has focused interest in bipolar disorders, OCD, neuromodulation, and I think I can still go on and on. He has so many accolades to his father. But without wasting time, I would like to hear and let you all listen to the great speaker, Dr. Reddy sir. Over to you, Reddy sir.
Thank you. Thank you so much for your very kind words, Dr. Kathy. First of all, I thank Dr. Ashwin for giving me this opportunity to be sharing my thoughts on neuromodulation. I think while introducing the topic, he talked about interventional psychiatry. So I think that is something which is very nice to hear. Only pretty late only we start talking about it. Yeah, able to see my slides?
Yes,
Are you able
doctor.
to see my slides? Yeah.
Yes, we can.
Yeah, right. Today, in the next half an hour or 40 minutes, so I'm going to give a broad overview of transcranial magnetic stimulation. It's really exciting. Now, like one of the most exciting things is that number one, it is non-invasive. Second thing is a very, very safe treatment. Let me re-emphasize that it's one of the safest treatments, and it's proving to be quite effective with FDA approvals coming up both for MDD and OCD and also for tobacco, now like smoking, de-addiction, it's been there. So today, let me run you through what exactly is the concept of this neuromodulation. Is it something new, or we have been having this concept for a long time, but this is a kind of a re-energizing, reinventing neuromodulation. That is what I'm going to look at. And I'll be focusing mostly on MDD and OCD. Dr. Kathy, I think, rightly pointed out the indications are getting extended to pain, Parkinsonism, stroke rehabilitation, and the multiple indications are coming up. But the FDA approvals are very limited as of today. So if you look into transcranial magnetic stimulation, I think looking at it, let's focus on only these two indications, MDD, OCD. As in today, if you look at it, we have the pharmacotherapy. I think every one of us agree that pharmacotherapy is the mainstay and definitely supplemented or augmented by cognitive behavior therapy. The third, non-invasive brain stimulation. This is the interventional strategy. What Dr. Ashwin was talking about, interventional psychiatry. As on today, this is only a third augmenting agent. It may be a little bit on the high side if we say that it can be third alternative. I don't dare to say this is an alternative today. This is in addition to pharmacotherapy, standalone, whether we can, maybe someday we may be able to see that. There are some patients who refuse to take medicines. They don't want to go through the, like a counseling period. Do we have anything else? Previously, we used to say that nothing. Today, we can offer. I can't comment on how activity, but we do have some patients who are opting only for this and then take times as a third augmenting intervention in the treatment of MDD and OCD. Let me limit to that. Now, what is the basis for this? Here, if I can look at it, see this. Brain is an electrochemical organ. I think this is the basic of it. Now, I'm going to the basic. Maybe you have to bear with me for a few minutes to talk about it. We all talk about, I think it's become a very, from the day one, somebody joins a DPMMD, depression, OCD, sir, because of some chemical disturbances, neurochemical disturbances in the brain. Even a layman knows about it. So we talk so much about the chemical thing, but I think we also have to remember brain is electrical organ, which is variable. You don't need to have any evidence. Just one EEG recording shows that the kind of an electrical activity which goes on in the brain. And then this very clearly, these two parts of this slide, the electrical and then chemical part of it, this sometimes I wonder, a lot of us, almost every psychiatrist talks as if he's visualizing a synapse there, presynaptic and then postsynaptic neuron and the synaptic cleft and the neurotransmitters getting released into the synaptic cleft and then in the receptors here. If we talk about serotonin, norepinephrine, dopamine receptor, it's almost like as if we see that. That is the kind of a thing which has been drilled into that regarding the neurochemical disturbances and the brain being an electrochemical organ. These two components, I think we need to remember. This is what we have been practicing for the last 70 years. From the time, the start of chlorpromazine and then whether it is imipramine or amitriptyline where it started, now SSRIs. This is the main focus, the background theoretical hypothesis on which MDD and OCD are based. Right? EEG, and then this is the neurotransmitters and the neuromodulators we talk about, norepinephrine, dopamine, and others. Suppose you look at the Parkinsonism treatment, just for an example. Parkinsonism also, they use these modulators, dopaminergic system, anticholinergic. This is the medication when it comes to pharmacotherapy, they use this. But they also, some of the resistant cases, the severe cases, this has become of late one of the very useful treatment modality in chemical part. Can we extend a similar kind of hypothesis or a principle even in psychiatry? We all know about SSRI, serotonergic system, and can we also take an advantage of brain being an electrical organ? And then is there any way we can do neuromodulation as an augment and alternate? That's what I'm talking about. This is what I talk about. And this is going to be the main focus. The similar way, as it's shown results in Parkinsonism, there's a scope. There seems to be already some evidence, there's scope for this. Now, this particular short video I show, you look at this. This is how the the internal neurons, the firing happens. Look at this. This is the firing. These are the neurons and axons and dendrites. This is what the firing happens, right? And this is a regular activity in the brain, which is an electrical activity which is happening. And now you see here very specifically, very specifically, a neuron, the axon, and the electrical activity, the way neurotransmitters production and then it's being transmitted. I'll show you in this, not the next few seconds. If you look at this is a neuronal body, this is the axon, this is where the synapse we are talking about. If you see this, till now, we were talking about this focus mainly on presynaptic, postsynaptic, vesicles, neurotransmitters getting released, and then the receptors. And then where all our pharmacotherapy is focused on. Now, going beyond this, now what I say is that the next one, here, let me see that. This is the part we talked about. In neuromodulation, what we are doing is that by TMS, we are generating action potentials. We are extending one step forward. We are focusing on this till now. Now, with the TMS, we are generating action potentials, which runs down the axon, opens the calcium channels. Once there's a calcium channel open, entry of calcium into that, and the whole process is the same thing. Synaptic vesicles, neurotransmitters getting released, they are coming into the synaptic cleft, and then the receptors. This process is the same which we are targeting with our pharmacotherapy, like vesicles and then neurotransmitters. But now, in addition to that, with TMS, we are generating action potentials and strengthening, maybe augmenting whatever we are doing till yesterday. That is the whole basic principle of TMS. Now, is TMS something very new? If you look at historically, let me run through this slide now quickly. Now I can have 5 seconds. We had asylums all along where all the patients, whatever may be that, anybody who has got a psychotic disruptive behavior are put in asylums, but they did not absolutely, it's almost like it failed the system. Then in the first half of 20th century, two disruptive events, if I can call it as a disruptive, which I definitely say that one is Freud psychoanalysis, second thing, behavioral school. These are the two disruptive events which maybe they have taken into the psychological realm, but they got the patient out of asylums. We have to give credit to these two persons. They got the patient from psychiatric disorders out of asylums and into the community. And then 30s itself, there is neuromodulation. ECT is nothing but non-invasive brain stimulation, neuromodulation. Psychosurgery is nothing but invasive neuromodulation. Psychosurgery, I think all of you know that he got the Nobel Prize for that. But for clear-cut reasons, it has gone into oblivion. But ECT still remains. But maybe Western countries not much of it, but we still use that. This is the first half of 20th century. And come to the second half, starting from 50s, we started leaning more and more onto pharmacotherapy. Clotrimazole, imipramine, SSRI, second generation antipsychotics. It continues. The dominance of pharmacotherapy was so much for more than half a century that completely dominated the therapeutic intervention psychiatry. For clear-cut reasons, pharmacotherapy made a huge difference, both whether you take schizophrenia or bipolar or any psychosis and depression, OCD, it made a lot of difference. And now, 21st century, once again, the neuromodulation is revisited. This is because of so much of knowledge has come into neurobiology, whatever is called as a decade of the brain, and no more and more emphasis on the connectivity. That is where neuromodulation is revisited. And especially the most important thing being, this is much more safer. Psychosurgery, we all know what are the side effects. ECT, of course, for some patients, it's a very, very useful, but we have to live with the cognitive deficits. The one advantage with TMS is that in quite a lot of patients, it's a cognitive enhancer also. That is the effect and side effect. That's an advantage of it. Anyway, telepsychiatry, I don't think I'll go into that. But one of the major advances I look at it is telepsychiatry is going to be very, very helpful for us to reach the last mile, which is accessibility of psychiatric care. This is broadly historically. First half, this is the knowledge disruption, then neuromodulation, gone into oblivion, then again pharmacotherapy. Now, once again, neuromodulation is revisited. This is the basic physics behind electromagnetic therapy. This is, here you see, this is circuit here. Electrical current flows into that, generates a magnetic field. This again gets into another loop of electrodes and generates electrical field. You see this? Electrical stimulation, magnetic field, once again getting converted into the electrical field, where you see the voltage changes. Then the question is, why do we have to do this electrical to magnetic to electrical? The only one reason being, if you have to send a sufficient amount of electricity into the system, into the organs, into the brain, there's a significant impedance of the skin and then bone. So you need to use a very powerful strength of the electrical current, which can produce side effects in superficial layers if you have to stimulate the deeper layers. That is why we, they fell into this, the famous physics principle, Faraday's principle, where here you don't have to apply so much of electrical strength, but internally stimulation can be generated. This is a major basic underlying physics principle of TMS. Then what is the difference between ECT and then TM? ECT, we give the electrical strength, which is a convulsive potential. Here, it's predominantly or almost always non-convulsive strength. That is convulsive, this is non-convulsive, but this is the basic core, the background of TMS, transcranial magnetic stimulation. Now, if I show you here, this is the different coils, how you apply electrical current, magnetic current to the brain. This is like we all know that figure of 8 coil. There are a lot of companies manufacture this, like MagVenture, Maxim, Neurosoft, and all that. What we have, this is what is deep TMS. This is manufactured by one particular company where it has patented. These are called helmet coils. That's what H coils. Here the advantage is, here this traditional figure of 8 and ambivert coil is that specifically for a very focal, highly focal. Here it is, the advantage here is the depth. That is why we call this as the deep TMS. For each indication, they have a different coil. This is for H1, this is for depression. Here the main target is dorsolateral prefrontal cortex. This is how the architecture of the helmet is. This is for OCD. Here if you look at it, here the architecture is such that the stimulus mainly goes to anterior cingulate cortex, ventromedial prefrontal cortex, and orbitofrontal cortex. That is why the configuration of the coil is such a way it delivers the electrical current of the magnetic field at the particular point and the depth where you want it. This is mainly for the smoking, where the target area is insula. So this is the advantage of deep TMS. Here it's much more superficial. I'll come to it a bit later, the coils. If you look at this is the helmet coil where you see the configuration of it. This is the figure of 8 coil. Here it's very highly focal. The generation of the electrical field is exactly at this. This is the 2 alternating current circuits. It's exactly this. The advantage is this is highly focal. The disadvantage is that unless you're very specifically locating the this coil, you may miss the target. Here the advantage is it's much more broader and deeper. So it's a very, very unlikely that you'll miss the target. That is the advantage of helmet coils. This is another thing. Why you call it deep? If you look at this is what I was talking about. This is the distance into the brain tissue from the scalp. If you look at this is the brain tissue. From scalp to up to the skull, 1.5 centimeters of the outer surface is with skin, scalp, and the skull bone. It's only after this 1.5 centimeters there is a brain tissue here. This is 100. This is this is the electrical field strength 100 volts per meter. Only if the electrical field is above this, it can stimulate the brain neurons. If it is below this, it is sub-strength and sub-electrical field. It cannot stimulate. If you look at these 2 coils, this is a figure of 8 coil. This is H1 coil. Administrating TMS with figure of 8 coil, the depth of it is almost like 2.2, 2.1. It's only 0.7 centimeters into the depth of it. Figure of 8 coil can stimulate. The same thing with H1 coil, it can come up to almost about 3.2. That's almost extending to 1.7 centimeters depth. So this is a major advantage of deep TMS compared to figure of 8. Figure of 8 coil can stimulate only up to the superficial 0.7, 0.8 centimeters. Here, it can come almost 1 centimeter down into the neural tissue where it can stimulate the brain tissue so that the required strength of electrical field remains in that. That's one of the major advantages of helmet coils. That is why, especially in OCD, it's supposed to be much more effective. So far, we did talk about broadly neuromodulation over a period of the last century, what it is, the basic physics principle of it, different coils, what are available, both deep and figure of 8 coils. Next, let's see that same thing. If it is shown here, figure of 8 coil, this red portion, which is, as I told, that the electrical field strength, which is required to stimulate and generate action potentials. With figure of 8, this is the small area. With the H1 coil, you see the depth of it. It's much more broader and then deeper. The advantage being here, if you don't keep the coil exactly at the location, there's a high possibility of missing the target. Here, that will not be there. And also the depth, especially if you look at H4, H7, it can go much more into this area where it can stimulate subgenual anti-cingulate cortex. That's one advantage of helmet coils. Yeah, this slide clearly shows the thickness of the skull. The blue areas, the red areas, if you see that, scalp to cortex distance 10 millimeters. That means its relatively skull bone is thinner. To come down, it is 23 millimeters, almost more than double. It's a superficial areas, it's more than double. Here in the temporal bone and all things, it's much less. Depending on this, which area you're going to stimulate, you decide the intensity of the motor threshold we check and intensity of the field what we give. It depends on this. That's where it becomes a very useful to know the scalp and the thickness of the skull here. Now, I'll quickly run through some of the literature, what is available now. This is now like a one paper, Lefaucheur, evidence-based guidelines on the therapeutic use of TMS. It's an update. Actually, this group of authors have been publishing this. It's almost every decade. The latest is 2020. A group of European experts reappraised the guidelines. As on today, this paper clearly indicates that higher evidence of efficacy is present in the areas of depression, pain, and then post-acute motor stroke. These areas I'm not talking about now because a little bit on the more of a neurologist arena, so more focused on the depression and also OCD. This has been in 2020. It is covered up to 18. OCD FDA approval has come in 18, so I think they would have missed this. But depression, high evidence of efficacy in the treatment of depression, resistant depression even in the early stage. This is the paper which is in 2020 talk about. And this is another group publishing a series. First their publication in 98 and again 2009 and latest 2020. This group mainly looks at safety and recommendations. How safe is TMS? See, when we look at repetitive administration of a brain stimulation to brain over a period of time, the most important thing is, along with the efficacy, it has to be safe. How safe that is going to be one of the very, very important things. Here, very clearly, they say that this is one of the very safe treatments. That is clearly, it has been mentioned in that. That is not like, I think that's where these two articles I'm mentioning here. And then, efficacy part of it will come a bit later. What are the side effects? I'll almost say there's virtually no side effect, but I don't think there's anything, there's without any side effects. Most of the common side effects are headache, a little bit of giddiness, rarely nausea, sometimes a little bit of muscle twitches on the face, which are very, very benign. If at all you talk about one significant side effect is seizures. Seizure can happen. Obviously, we are stimulating the brain repetitively for 20 minutes and then over a period of time, a day after day, so seizures. So, what is the risk of seizures? I don't know whether I need to even talk about the seizures because this is the risk of seizures, 0.00037%. It is virtually non-existent, but it can be an important even during the administration. So we do have to know about that seizure is now one of the side effects, which is now very rare, but a side effect of it. Then initially when I was we were using that TMS fairly regularly. Actually, at our center, we have been having the figure of 8 coil for the last 10 years and deep TMS for the last 2 years, we have been using fairly regularly. Got a lot of patients. I'll do the data also. The initial period, I was seriously worried. See, ECT, electroconvulsive therapy, you give at the most maybe, maximum maybe 10. You give it on alternate days. and then very brief, it may be just 2 seconds or 3 seconds or less than that, you now target the brain with the electrical current. But here it's not like that. It's a 20-minute sessions. If it is ITBS, maybe 3 minutes, but regular sessions are 20 minutes. You target the brain 20 minutes day after day for a good length of 4 weeks or 5 weeks. I was seriously concerned about several theories, then kindling phenomenon, all that, whether there will be an increased risk of seizure, which was a constant worry for me. But I'll tell you, in the last 2 years, I've shared the data. We had seizures only for 2 patients. Actually, both the patients are my patients. One patient, he had seizure almost about 12 hours after the, now he had a past history of seizure, 12 hours after the TMS. Second patient was in the withdrawal period, zolpidem withdrawal period, he had a seizure. Otherwise, we didn't have any of the patients having seizures. And most important thing which I want to emphasize there is that even though seizure is an important event, but it's very rare, but still this is an important thing. About 60% of seizures occurred in the first exposure, and 75% occurred in the first 3. This is a very, very reassuring data for me. So, this clearly shows that repetitive exposures will not increase the risk of seizure. If at all somebody has a seizure, it's more of an individual susceptibility. That is why 60% of the times it happened in the day very fast, and 75% first 3 exposures. So if any of a patient did not have seizure in first 4 or 5 sessions, it's a very, very unlikely he's going to have a seizure, which is very reassuring, especially now keeping in mind that kindling phenomena. That is why I wanted to show this slide saying that there is a risk, but it's a very, very insignificant. And also, if it is there, it is there in the first few sessions. Otherwise, it's almost not there. That's very, very reassuring. Now, TMS, when we use it, we stimulate the brain. But how do we know that? What exactly the kind of inside what is happening? So here, the combined use of TMS with MRI, spectroscopy, and then diffusion weighted, and especially fMRI. I'm going to show you one study where it's been linked to fMRI, especially being helpful in regions which are directly stimulated by TMS. fMRI is going to be very, very useful if you can link TMS with an fMRI machine. And that one of the studies from Ranchi, I'm going to show you that this is one advantage of this TMS, which we can find out exactly which areas of the brain are functionally becoming active or being stimulated. This is one of the 2022 papers. There are, FDA approvals for, as I told, that MDD and then OCD. This paper shows that approval for the anxious depression, where you see the sham control, and then actually at the end of 4 weeks, the difference obviously you see in a change in the scores. And this is another, a review paper where 22 clinical trials, where H7 is mainly for the OCD, and then the response rates were significant, 72% and 52%. It's not it's a lot of data getting accumulated saying that OCD, there's very good response, and also to the extent of remission, which more data I'll be showing you later. This is what I was telling you about. This paper, this Reddy is not me, that is some other Reddy. This paper is from Ranchi, like Nishant Goel. 15 OCD patients, they're given 10 sessions for each. This is where they have done fMRI study also. They used Stroop task, for fMRI. Very significant improvement in the OCD, anxiety, depressive symptoms. And they also find that a correlation decreases activation of left caudate. Mostly we talk about OCD being, in the area being striatum. The conclusion in this is that the study provides preliminary evidence that functional correlates of effectiveness of deep TMS as an adjunctive treatment modality for OCD. So fMRI gives us a clear indication what exactly is happening inside the brain with this functional recording. Otherwise, we only have to depend on the HAM-Ds and then Box. That's where it becomes a very important study, this study from Ranchi. Now, generally till now, I talked about depression, OCD only for resistant depression. Here, there's a paper which has come in 2019. The kind of efficacy is so much. This particular author says that literature review of clinical efficacy of TMS. He says that why do we have to wait till it becomes a resistant depression, resistant OCD? can we initiate this in the initial period itself so that we won't lose time? So this paper, I only wanted to show the growing confidence in the efficacy of TMS among the people who are using that. That shows that since they don't have to wait, even less than one medication trial should be considered. The use of TMS as early as possible should be considered. That is the significance of this paper, which has come in 2019. This is typically, how do we administer 2-second train and intertrain interval. I don't think I have time to go into the details of how actually the treatment is administered. Usually it happens for about 20-minute sessions. 2-second trains where it's about 18 pulses are given. Then there's a 20-second intertrain interval where there's a quiescent period. Again, one more train. These are called trains in a typical session for depression or OCD. It's about 2 seconds, 20 seconds of dormant phase, again 2 seconds of stimulation, like that about 55 to 60. So totally in a session, we give about 1900 to 2000 pulses. This is again another variant of stimulation where it is theta bot stimulation. That is 3 pulses at the rate of 50 head, 3 at a time it's given 3. I think we all know that easy. Alpha, beta, theta. Theta is in the train 3 to 4. That is why it is named as this. This is a very shorter protocols, 3-minute protocols. The standard protocols are 20 minutes. Maybe sometime later we can take up what exactly administration. How do you do screening? Screening is very important. The screening is like what you do for MRI. Any element which is magnetically stimulating on the body, you have to take care of it. It's especially like the aneurysmal clips, sometimes pacemakers and stents, and then sometimes dental implants, anything which reacts to the magnetic stimulation, that you have to be. Sometimes it's a cochlear implant is a complete no contraindication. The other are relative contraindications. As you all know that whatever, if somebody can go into an MRA, he can come into treatment for TMS. It's a kind of a basic principle. We do the screening. This particular slide and then study I want to show you. Till now, I was talking about 20-minute sessions, daily one session, extending for about 6 weeks. This has come as a revolutionary thing, Saints Protocol, Stanford Accelerated Intelligent Neuromodulation Therapy, published in 2020. The results are actually mind-boggling, actually hard to believe kind of a thing. What these people have done is that every day they give ITBS, that is theta bot stimulation, 10-minute sessions. Every day they give 10 sessions per day. This is day 1, day 2, 5 days, 10 sessions per day. It is, like at that time, when they published the paper, there was a lot of excitement about it. So the whole treatment of neuromodulation is being condensed into 5 days. 10 sessions per day. Between 2 sessions, there has to be a gap of 1 hour. So the patient has to be outpatient or inpatient. Patient has to be in the, for almost 10 hours or 12 hours. So this is it's a kind of a remarkable kind of thing. They have patented this particular kind of procedure because they have did it neuronavigation. After that, they did a stimulation. So the underlying simplifying this is that ITBS, 10 minutes each session, 10 sessions per day, for 5 days. The total of delivery is about 90,000 pulses for each individual. You look at the results. It is as on today, when Dr. Rashmin talked about interventional psychiatry, today, for us, it's just like unbelievable on one side. It's a dream like on another side. I'm not trying to sell the concept of neuromodulation or deep TMS. It almost sounds like that. But it's difficult to almost believe. Look at this. Day 5, Saints Protocol after administration, the response and MADRS scales, response and remission are 90%. I think it's a dream for me. Generally, when people talk about, we all talk about depression, I think we have reasonably good SSRIs, I made all the change. When somebody asks me, Dr. Reddy, what is your wish list for the treatment? I say only one thing, 1, 2, 3. I want an antidepressant which can show the results in a week. Because 3 weeks, 4 weeks period is doing a huge problem to keep the patient with us. You know that this medication works, the pharmacotherapy works, but to keep the patient for 3 weeks without much of a change, it is a huge challenge. Now the Saints Protocol has given us a tool where at day 5, the response is 90%. It's almost like unbelievable. This is a study where they have done in 2020. They followed up it 2022 as RCT, Stanford Neuromodulation Therapy. You look at the figures here. Remission and response rates with TMS. This can be along with pharmacotherapy. I'm sure the pharmacotherapy thing now, like we know how much time it takes. Let's look at 0 means day 5. 1 means a week after that. 0, 1 weeks, the remission rates are 57% and 71% remission. 71% remission at the end of second week or 57% at the end of day 5. These are response rates. Compared to the sham, where we all know that it's a 7%. A sham TMS, this is sham control study. So when you give a Saints protocol, ITBS, 10 sessions per day for 5 days, according to these papers, the response and remission rates are 50 to 70% on day 5. If these results are replicated, all over the world and majority of patients, this is going to be a complete game changer in the treatment of depression. There is no doubt about it. But now, we need to replicate it in a larger population across the world in all different, geographical, different type of groups. But this is a recent paper. Hopefully in the next decade, we see a lot of these papers getting published like this. This is the data from our study from Hyderabad. So as I told you that we have been doing this, administering deep TMS in the last 2 years. So we have published this data. Let's look at MDD and OCD, 391 patients, 231. On day 6, the response rates are 60. OCD, day 10, 30% change in the Y-box score, it's a 62%. This is something which again, generally when I present this, I keep telling that if I'm on the other side of the group, I generally refuse to believe it, but this is the fact. This is where the whole beauty of TMS lies. The speed of these three triple R's are response, remission, and then recovery. What is the speed of this? What is the rate of persistence? What are the dropout rates? How many dropout rates? It's very. Today it's a little bit on the costly side, but still we don't see much of dropout rate. Cost effectiveness, if it has to be accessible and scalable, definitely the cost has to come down if it has to go to the common man. Today, let me tell you, we charge almost about 3,000 to 4,000 per session. So if it is for the depression, it costs about 40. If it is OCD, it costs about 50, 60,000, which is definitely for a lower middle class person or a poor person, it's going to be a bit costly compared to the pharmacotherapy. But when you include the psychotherapy and the number of sessions, 15 sessions, it may not be, but cost has to come down. So the speed is something which is mind-boggling. There's not much of a dropout. Adverse events, as I told you, hardly anything. In this patient, as I told you, that in this patient, I've seen only 2 seizures having. Health economics is one important thing which we have to look at. If we have to get TMS into the average clinics, every clinic. Right now, we are having 2 of these papers. Both of these are our DNB students' dissertations, which we are doing deep TMS or sham. We have a sham machine, coil machine also. One is for OCD, one is for bipolar depression. It's going on. Their dissertation works. Once it is completed, let's hope that the results will be positive. We also have published one paper. It's a case report. This is another thing which is a very, very encouraging thing. One patient with tardive dyskinesia, which did not help with almost all kind of indications, including clozapine. As a last resort, we tried TMS, deep TMS. There's a significant an improvement in the scores, which were published in the recent Asian Journal of Psychiatry. And there is, I think, another 4 or 5 patients which we are going to publish for in a case series. As I was telling you that efficacy and safety of, at this point, some people will ask that, what is the difference between figure of 8 coil and deep TMS? See, as in today, very few papers comparing these two. This one paper in 2024, both of them show reasonable reports, but deep TMS leads to a better antidepressant response. Both interventions have favorable safety profiles. This is the only thing we can conclude now. But the cost-wise, there's a significant difference in the machine cost of figure of 8 coil and also the deep TMS. This is something which I just wanted to show. Not significant difference, but there's definitely a difference when it comes to deep TMS because of maybe so many reasons. This is the machine. This is a deep TMS machine manufactured by an Israel company. This each indication there's a coil. This coil is for depression. This coil is for OCD. For now smoking, and then now there's a different coil. Each coil targets a specific area. As I told, the depression coils targets dorsolateral prefrontal cortex. Then OCD mainly targets the deeper areas, including anti-cingulate cortex. So OCD broadly, we all know this is something which I don't have to tell you. These are all the general things. Like we need a lot of our OCD patients are resistant. In addition to pharmacotherapy and then CBT, we need a third. Anything else? I think maybe TMS can chip in. Management of OCD, we know that this is what I don't think psychosurgery is being practiced. Now there's a deep brain stimulation. There's a study going on in NIMHANS, deep brain stimulation for OCD, which not like a very few patients they have. So at this point, TDCS, there is no FDA approval. ECT, we all know that it's not really effective in OCD. So when it comes to the third alternative, sort of augment pharmacotherapy, cognitive, third comes the TMS comes as one useful option in the management of OCD, need not be resistant even from the beginning. So that can be targeting these areas, medial prefrontal cortex, anti-cingulate, and orbitofrontal. We all know that CSTC circuits, this is where the stimulation is being targeted. I don't want to go into the details. This is one interesting area. Maybe I'll just take another 4-5 minutes. This is theoretically very, very fantastic and then exciting. In the treatment of OCD, this is the two papers which are common, 19 and again 22. Symptom provocation for treatment of OCD using TMS. The provocation is mainly stimulating CSTC circuits. According to the theory, it's really a lot of excitement when I read this, but I don't know how far it's going to be practically useful. The theory is, before administration of TMS, you ask the patient to imagine something of, whether it is obsession or compulsion, where it can trigger anxiety. That is symptom provocation, a specific thing. When you ask him to give a symptom provocation, it automatically is supposed to trigger a particular circuit. Once a memory trace is retrieved, that is, whatever the thought or a compulsive act or thought process triggers a particular neural circuit in the brain. I'm talking about very, very specific things, but how specific it can be, don't ask me about that. The memory trace is retrieved. This particular circuit which becomes active, I believe it becomes labile for a period of time for the next 6 hours. That means when somebody is having compulsive washing, you ask him to imagine a scene where the hand is dirty. That releases anxiety, and that particular time, a particular circuit in the brain is becoming more and more active. Once a circuit which becomes active, this has got a window period of about 6 hours where it can be modulated. So once you activate with symptom provocation and then apply TMS, this is different from ERP. ERP is a continuous process, unlike lasting for about an hour or something. This is only for 2-3 minutes. And then at that period, during the 6 hours period, disrupting the reconsolidation in memory electrical stimulation is supposed to help patients with OCD in preventing the reconsolidation of this repetitive and recurrent thought. This is now like a very exciting theoretical possibility. Let's see in the long run how is it going to come into use when we apply symptom provocation in the management of OCD with TMS. Right. This is just for the completion's sake. We all know that what is the basic underlying principle? Neuroplasticity. That's it. Neuroplasticity is nothing but now like an ability of the nervous system to change its activity in response to intrinsic, extrinsic. Here it is extrinsic stimuli by reorganizing its structure, functions, and connections. So reorganizing, whether it is for depression or OCD or any other kind of neurological condition. You all know Hebbian plasticity rule. The neurons that fire together wire together. That is where we look at, and the behavioral time scale also we are looking at. This is generally the OCD protocol. About 28 sessions, 10-20 minutes. That's what I was talking about. We establish a motor threshold, the details of which maybe some other time we can take it up. 100 or 120%. This is the stimulus frequency, 2 seconds, 20. This is what I told the number of times, and totally about 2000 pulses. Each session about 1900 to 2000 pulses. And like that, about 20 sessions or 30 sessions, depending on the individual person. Generally, it's about 28 sessions. As on today, regarding the maintenance sessions, we don't have a specific protocols. Now, talking about the protocol, let me tell you, FDA approved protocols are generally one session for each day, 5 days a week, lasting for about 6 weeks or 4 weeks, depending on whether it is OCD. Nowadays, it's more and more emphasis is coming on accelerated protocols. The amount of stimuli is the same, the number of sessions can be the same. That is why I showed you. So just imagine, patient has to come every day, 5 days a week for the next 6 weeks. Compare that with Saints protocol, where they have done 10 sessions per day for 5 days. TMS treatment is over. The focus is shifting more and more to accelerated protocol, which I think is the most welcome step. If it takes off, I think maybe, possibly, hopefully, TMS can be a game changer in the management of, now, at least to start with MDD and OCD, maybe other psychiatric disorders. Thank you. Thank you very much. Thank you all for a very patient listening. Now, what are the few questions if you have? I'm open to that. Thanks. Thank you so much.
Thank you so much, sir. That was really very elaborately and beautifully described, starting from the basic mechanisms to all the types of coils and especially that activating symptom. That's very interesting. So I really thank you so much for such a vivid and wonderful lecture. Now
Thank
the seminar is open for discussion. I welcome the questions.
People can put up their questions in the chat box, and then Dr. Metale and Dr. Reddy will address those.
So, in the meantime, sir, I would want to ask a basic question. Like, as you said, that this is basic, the mechanism of neuromodulation, that it activates the synapses and the calcium channels and everything. I think that is the same mechanism which is used, like, that is what works in ECT as well, right? Now, when we are giving the medicines, we are selectively targeting particular neurotransmitters. But when we are giving either ECT or say TMS, we cannot target any particular neurotransmitter or any particular channel. But still, somehow we get the favorable result. So, what might be happening in that? Possibly.
That's, I think, is again still like $1 million question. 1930s CCT has come. Still, we do not know what exactly it does. But no, like the beautiful thing about ECT is, maybe I talk about some patients, very selective, extreme depression, severe depression, psychotic, severely retarded, virtually like catatonic. ECT melts. ECT melts in the inpatient theater, which I don't think any of us can explain what exactly happens inside. But that's the only thing which I keep talking about. If ECT is working so effectively, the only difference between ECT and TMS is that's a convulsive potential. This is non-convulsive potential electrical field we are applying. Beyond that, we are still ignorant about what exactly is happening where. Maybe the studies combining fMRI and then TMS can throw a lot of weight. Which are the areas, primary areas, secondary areas where it's getting stimulated, which is not like an, especially the bold, not like an oxygen intake is more. Maybe that can throw more light on that. Beyond that, right now, it's very, very difficult. Once again, it's much more safer, and then no need for anesthesia and then walk in, walk out. That is a great
Yeah, yeah.
advantage. Cognitive deficits are zero. And then side effect profile was it's much on the favorable side. That is the main thing.
Yes,
There
sir.
are few questions here. Any studies comparing antidepressants with TMS? See, as on today, TMS is only an augmenting agent. It's not like an either antidepressant or TMS. As I told you, maybe I think we have about 1,000 patients. Maybe those who opted only for TMS are maybe a handful, 4, 5. If you ask me, can I confidently prescribe that? As of today, no, I don't have the confidence, but maybe sometime later it may. Even for ECT, if you see that, ECT, even though we give, but patient has to be on pharmacotherapy in the follow-up. So without that, we don't. So I don't think, as of today, there's nothing. Effectiveness for severe OCD, yes, OCD definitely. Severe or no, moderate OCD, definitely there are quite a lot of studies showing that its effectiveness. OCD related with schizophrenia, how serious patients have responded. OCD, it's like definitely the response is positive, number one. Number two, the most beautiful thing is that some of the patients, they do come back and ask for maintenance TMS because this is one treatment which has given me a significant relief from my compulsions and then obsessions. But this is all something as in today we cannot categorize like that, whether it is obsessions or compulsions. There is no doubt about it. OCD, this definitely, at least in a small group of patients with OCD, this is very effective. rTMS in catatonia, as in today, I don't think we can try that. Maybe we have to try in individual patients later because catatonia, the first choice will be ECT. So here, another thing is catatonia. One of the problems could be that patient has to be a little bit cooperative and sit in the chair for almost 20 minutes. That may throw some challenges where ECT, it may not be. Thank you so much. Treatment-resistant depression, what should be preferred between TMS or ECT? Since both are there in the guidelines, is there any comparative study? See, ECT as of today, I don't think anybody has any questions, except that even ECT does not work for every patient with MDD. It has got its own specific indications. As I told that some of the suicidal, psychotic, retarded, their ECT is the best. But suppose an elderly person or somebody with a minor age group, there, I think definitely TMS can be. And then where you had a past history, significant cognitive deficits, you don't go for ECT. So that is where TMS can chip in. TMS induced seizure harmful. Same thing, it's not harmful. Actually, even the stupid, strictly speaking, seizure as a side effect of TMS, according to the textbook, it has to happen during the session or at least within half an hour, which was not the case with us. So one seizure, like any other, generally like in neurological practice, one seizure is not treated. So we can even leave it. The same thing as ECT seizure. Even in ECT seizures are very, very rare. The same way, it's not harmful. ADHD, right. As in today, below the age of 18, it is not no approval. But out of like in a box indications, it's like this. Mostly our clinic has 90% MDD OCD. But we have treated a few patients with Parkinsonism who read about it and walked in saying that we are not expecting any kind of it, but we can give it a try. Same way, one patient in our Bangalore center, somebody about 25 years, autistic spectrum disorder. I'm not putting as an indication for that. They read about it and then came, and then the report is that there's a significant improvement in the behavioral symptoms in ASD. That is what a single case reports. We are trying to collect some of the case reports and publish. ADHD, we have not. We have not tried also. One problem with helmet is that the child's head size is small. The helmet, like sometimes it doesn't fit in. We do use pads, but it doesn't fit in. Then whether we can induce the sufficient amount of electrical field is doubtful. So we don't try it regularly. What protocol? ASD, it's mainly the depression protocol. Depression protocol only. We don't have a specific thing that is way. As on today, availability in India, deep TMS is only one particular manufacturer. all over the world. There's only one particular manufacturer for the helmet coils. The other figure of eight coils, there are quite a few names. At least I know about five, six, both local and also the imported, five, six different machines are available. It's like broadly there should not be any major difference, but we do not know. Here the point is that if you ask me, what exactly is the strength of the electrical field which gets generated in the brain, it's very difficult to talk about it. Unless whatever the manufacturers say, we have to believe it. Beyond that, I don't see any major difference. There's like simple machines, very easily operable, maintenance is very easy, there's no problems at all.
So I think we are done with the questions. I hand over to Dr. Rashmin.
Thank you. Thank you.
Brilliant. Absolutely brilliant. Thank you very much, Dr. Reddy. It was absolutely lucid presentation, as is endorsed by almost everybody who was listening to your delightful talk. Yes, you did address quite a few things. There are not too many people who understand rTMS as well. So maybe the questions will come fast and furious, maybe a few more years down the line when people have started using it, because there are very few people who are using rTMS yet, and even fewer who are using the deep coils, So almost all the studies that I have perused tell us that the deep coils are definitely more reliable and more effective for most of the patients. I don't know what your experience would be, but the few people who I've interacted with who are using the regular coils, they are getting equivocal results or maybe modest results as opposed to as encouraging results as your studies and your experience have told us. But it's really very exciting, and we are eagerly awaiting more and more options available to our patients. The primary challenge that we see is the frequency of the sessions and the cost, which probably becomes a prohibitive factor for people to dedicate a session every day for at least a month or a month and a half. I believe you give 5 sessions a week and then give a day or two to recover, and then in that manner.
This is the FDA approved protocol. But all over the world, the accelerated protocols have become more and more aggressively pushing for that, considering the safety. That's why I put about the Science protocol where they give 10 sessions. 10
But
sessions per day.
per day.
Per day.
Okay.
Science is 10 sessions per day for 5 days. This is gaining more and more acceptance, and then more studies are being done for FDA approval. And by the way, anyway, I think some of you must be definitely coming for ANSIPS Hyderabad. I welcome all of you.
Sure.
And just next month. So we are planning to have a hands-on kind of a workshop, kind of a symposium with a machine there,
Okay.
deep TMS. We're planning a 1-hour symposium on that. Any of you are interested, please do come.
Lovely.
I'm sure Dr. Rashmi will be there, Dr. Kathy will be there for ANSIPS. Anyone the others in the group also, you're most welcome. We're planning to do a workshop. Yeah.
Lovely. This could not have been a more apt time for your session in that case today. Thank you.
Thank you.
very
Thanks
much.
for that.
Thank you very much, Dr. Reddy. And thank you very much, Dr. Kathy, for being with us today and taking out your time and being with us on this evening. Thank you for the participants who have been quite active, and we have been seeing more and more senior consultants join in as well. So clearly, people like Dr. Reddy have a significant pull amongst almost all, not just postgraduate students. But thank you all for being a part of this. And of course, thank you, Sun Pharma, for being with us unflinchingly. So thank you once again, all of you. And I hope to see you again next month for another exciting chapter on the DY Patil Postgraduate Lecture Series. I wish you all a great evening, and I again take this opportunity to thank Dr. Reddy and Dr. Mehtalia to be with us. Thank you so much. Have a great
Thank
evening.
you. Thank you so much. Thanks everyone. Thanks. Thank you.
Yeah.